My name is Rasika Buddhiga, one of the anesthetic consultant from Teaching Hospital Kalpovila. Today we are going to talk about fluids and the the fluid, the management around the perioperative period. So we give fluid to almost every patient and every day, but ultimately if somebody asks how much fluid that we have to give and what type of fluid that we have to give and when should we give the fluid to the patient, so those questions still be few of the hardest questions to answer at the end. So that may be the reason people have called this talk as navigating fluid maze. And the simplest version, simplest meaning of this complicated topic of the presentation is optimizing perioperative fluid management. Okay, over the last few slides, the next few slide actually, I will try my best to keep it simple and practical to explain you the core knowledge of the fluid management. So why the fluid management become a maze? So let's begin with a simple question. Why is giving fluid sometimes we do every day is still so confusing? So I think the first reason is that there is no single correct answer to give for that question. Sometimes fluid management can, the change, the right amount of fluid that we have to give to the patient can be changed according to the patient's factors and their age and illnesses. And at the presentation of the patient to the theater, and we have to assess how dry or how wet they are to be start with the surgery. And also it changes with the surgical factors as well. I mean the amount of fluid and the fluid management that we have to do. And sometimes the fluid management can vary with the mode of anesthetic that we use. And the other reason is that the science also keep changing. I mean the changing physiological theories on fluid behavior in the body, it continuously updating. So physiology of fluid in the body has now been revised, updated, and we will come back to those updated knowledge in next few slides. And our fluid management strategies also has been updated from liberal to restrictive and to zero balance. I mean, restrictive and the zero balance managements are all same. And finally, to the goal directed, the newly recommended goal directed fluid management, finally. So if you can see, shall we go from the beginning? I mean, the basic core knowledge of the fluid and the physiology of the fluid and the fluid compartment in the body. So this slide shows, so the next, third slide, madam. So this slide shows where the water in the body actually sits. Suppose there is a 70 kilogram adult man. So about 60% of his body weight is water, which is roughly about 42 liters, as we all know. So we have learned this in our physiology in the medical school. And those 42 liters, and we can divide those 60%, which represent 42 liters, into two main compartments. And 2/3 of that 42 liters, it's about 28 liters, is inside the cell, which is considered as the intercellular fluid. The main electrolyte inside the cells are potassium and the magnesium, just to keep it in mind. The other 1/3 is about 14 liters is outside the cell, extracellular compartment. Here the main electrolyte is sodium. The fluid outside the cell again splits splits into two, and the major part of it, about 10.5 liters, lies between cells considered as the interstitial space, and only about 3.5 liters is in the plasma. It means considered as the intravascular fluid. The fourth slide, next slide, madam. So, and now you know about the fluid compartment, and this slide shows about the fluid spaces where the fluid lies in the body, or where the fluid can hide inside the body. So the first space is considered as the intracellular compartment, and it holds most of the body water. And the second space is the extracellular compartment, and it includes the fluid around the cells and sometimes the plasma in the blood vessels. So we are more considering about the third space here, and it is not the interstitial. Sometimes someone can think that the interstitial space would be the third compartment, but it's not. So the third compartment means the fluid that has moved somewhere, but which we can't use it, which cannot be used, um, I mean, can't occupy into the cells or into the intravascular space. So the examples are fluid which has been moved into the bowel lumen or the peritoneal cavity or to the pleural cavity. Second. Second, please. Okay. So the third space fluid, that fluid is still inside the body, but the patient can't use it effectively. But it hasn't not truly been lost from the body, but it's no longer available to the circulation. So, uh, so we knew about the compartment. So we discussed about the fluid spaces in the body. So we can move, to this Stalin forces theory to discuss about how the intravascular fluid is moved out of the vessels into the other compartment, and that is the main mechanism of distribution of the fluid that we are giving to the intravascular space, and ultimately that fluid volume will be distributed into the other compartment. So the fluid has to come out of the vessel. So there are two theories to explain that. So the one is Stalin forces. That it is the classic one, which is the old one, and it has been revised into the revised Stalin forces later. So we will discuss both of them together now. So if the fluid can move out of the vessels and uh, hide in somewhere, so the question that that will be come into the mind, the which kind of force that push fluid out of the vessels, or that is explained by the Stalin forces. Stalin said that fluid movement across the capillary wall depends on the balance between two pressures. One is hydrostatic pressure, which is exerted outward from the capillary lumen. That is the outward force. That is the main force that drives fluid out of the vessels. So, and the other one is the pulling pressure, which is the pressure and the force which keep the fluid inside the vessel, that called oncotic pressure. So the balance in between these two pressures will ultimately decide whether to push the water out from the vessels or take the water inside the vessel. Look at this capillary in the picture. At the arterial end, the net effect is the outward hydrostatic pressure. It means the total when we consider the balance of those forces, inward and outward forces, the hydrostatic pressure will be the more. So the net fluid movement will be towards the interstitium from the capillary. So the fluid filters out into the interstitium. So at the other end, it means the venular end, as the blood travels through the capillary, hydrostatic pressure falls gradually towards the venular end. And so the inward oncotic pressure will not be changed, and I mean it will increase gradually, and that will be the prominent force which pulls the fluid inside to the vessels. So from finally, the uh, final explanation would be the from the arterial end. So the fluid will be leaked out because of the more hydrostatic pressure, and from the venular end that will be absorbed again into the circulation. So the classical teaching was a simple like loop kind of explanation. Fluid leaves at one leaves from the one end, from the arterial end, and it will come back to the vessel again from the venular end. So the next slide that will explain about the new theory, endothelial glycocalyx. So the endothelial glycocalyx means that just keep this, the concept in mind. So that is important when we go into the learn about the revised Stalin forces in the next slide. So the glycocalyx layer is the thin inner surface of capillary of the endothelial layer that is coated inside the capillary, and that is a layer which consists of glycoprotein, glycosaminoglycans, and the protein, mainly the protein and the lipid and the sugar compounds. So, and as you can see, so I can't point that out. So you can see this brush border above the endothelial lining. So that brush border, underneath that border, there is a space called subglycocalyx space, which is protein free. That is the most important part of this discussion. So just beneath the glycocalyx layer, there will be a space which is protein free, and that is the main determinant to, decide the oncotic pressure, which keep the fluid inside the vessels. So this small layer changes everything. The force that holds the fluid inside the vessel does not come out from the interstitium. I mean, the initially it explained the inward pull of the fluid drives into the vessels because of the oncotic pressure inside the vessels, and the difference between the oncotic pressure in the interstitium and the vessel. But now it is not the way. So as the oncotic pressure in the subglycocalyc space is zero, so the driving force, inward driving force would be the balance in between the vessels and the subglycocalyc space, not the interstitium. That is the main factor, the new thing that has been used to discuss, develop the revised Stalin forces. In the next slide, the, the glycocalyx layer usually freely allowed to crystalloids to pass through. There are few gaps in the endothelial cell lining. The fluid can leak through the glycocalyx layer and through those gaps in the endothelium into the interstitium. But when consider the colloids, so they are large molecules which can't be go through the intact glycocalyx and through the endothelium, gaps in the endothelial cells. So the colloids tend to retain inside the vasculature. So if there are a few factors that can damage the glycocalyx, which I discussed in the next slide. So it considered, as I mentioned about the crystalloid and colloid here in this slide. So the FFP and the albumin partially restore. It can, rebuild the damaged glycocalyx thickness, which is an important thing that we can when we discuss the fluid management in next during the major surgeries in the perioperative period in next few slides. So as we already told you, when we discuss about the revised stalling for principle, so you can see the same capillary with that newly added glycocalyx layer inside. So not like in the previous old theory. So you can see the fluid is leaking throughout the vessels uh, according to the balance between the hydrostatic pressure and the oncotic pressure. So that is not something, I mean, arterial end or venular end. So that is not come into here. So the throughout the whole capillary, the fluid will be leaking out depending on those hydrostatic and the oncotic pressure difference. So how can those leaked fluid get back into the circulation? That is through the lymphatic vessels. So, if the endothelial calyx has been damaged because of some reason, so there will be more fluid leak out of the vessels, and so those if the lymphatics can't effectively drain those fluid back into the vasculature, there will be significant tissue edema. So, in next slide, we are going to talk about the what are the factors that can damage to the endothelial glycocalyx layer. So, uh, by now you have to know. I mean, by now you have to know about that the endothelial glycocalyx layer is the determinant part of the fluid movement from the capillaries. So if it has been damaged because of these reasons, hypoglycemia, sometimes inflammation, and there is some, it can be damaged because of the ischemia and reperfusion, and sometimes because of the oxidative stress and the hypovolemia and sepsis conditions. And these list of factors that can damage the endothelial glycocalyx, where you can have the hyperpermeability of the vessels because of the damaged endothelial glycocalyx, which can't maintain that hydrostatic pressure and the oncotic pressure, which can't regulate that oncotic pressure difference, which flavors to keep the fluid inside the vessel, and now the vessel become more permeable to fluids, and the I mean the small and large molecules both. So they will all come out to the interstitium, and the interstitial oncotic pressure will go up, and it will start retaining fluid inside the interstitium, causing significant tissue edema. So, what are the bad clinical consequences of damaged endothelial glycocalyx? As I already told you, so it increases the vascular permeability. So the protein, fluids, and the macromolecules will leak out into this interstitial space, causing severe tissue edema. So sometimes it regulates the production of nitric oxide inside the vessel, which causes the regional vasodilation that also can be impaired. And when the endothelial glycocalyx layer damage, it leads to a prothrombotic state because it accelerates the and promote the platelet aggregation. So the microthrombi formation can be increased, which is not good. So there are a few other consequences which we don't have to consider in perioperative period. So the increased vascular permeability and the impaired vasodilation and the prothrombotic states are the most important consequences with the damaged endothelial glycocalyx. So how to recover the damaged endothelial glycocalyx? There are a few ways which we can use, mainly the pharmacological agents that we can give to the patient to recover. I mean, we think that it will recover the endothelial glycocalyx, and it is an evidence-based finding. So albumin infusion. So usually I mean, in our day-to-day practice, for the major surgery, if we have to give some large volumes of crystalloid, usually we used to put some albumin into the next few. I mean, usually starting from third pint of normal saline, fourth pint of normal saline, like. So we use albumin to give albumin from the next use bottle of saline or the heart mask to reduce the amount of fluid that we give. So by that, I mean, look, by practicing that itself, which gives idea that the albumin will recover the endothelial glycocalyx, because the hypovolemia that we have loaded the patient with the crystalloid, then now endothelial glycocalyx layer will start shedding out. So then if we can give some albumin, so we think that the glycocalyx layer will replenished again and retaining the fluid inside, reducing the increased vascular permeability. So the glucocorticoids is the another thing that we can give to recover the glycocalyx layer, and antithrombin 3 and rational fluid management. It means not to make the patient hypervolemic, because when the patient become hypervolemic, your atrial natriuretic peptide, your atrias will get distended, and that will release the ANP, which has direct effect on the glycocalyx, which starts shedding out of the out glycocalyx layer and increasing the permeability. So hypovolemia itself a cause again. So other minor pharmacological agents that we can use to recover the glycocalyx layer. So you don't have to keep them in mind. So the important thing is albumin, glucocorticoids, and your rational fluid management. So after discussing about the basic physiological, I mean the stuffs and all, so now we are moving to the main part of the today's discussion. So the overview of the today's discussion is to discuss about the importance of fluid management in the perioperative period. And next, I will discuss about how to assess the fluid status, including the fluid responsiveness, and what type of the fluid that we can use in the perioperative period, including colloids, colloids, and the blood products. And finally, the fluid management strategies, liberal strategy, restrictive strategy, and finally the goal-directed strategy. And the fluid that we have used in special circumstances as the final topic. So the importance of IV fluid in the perioperative period. So actually the fluid now has been considered as the drug, as we all are using drugs to induce the patient, and as antiemetics, analgesics, and all. So the fluid also considered as a drugs, which we have to have more concerns on the management. Mainly, the fluid is being used to restore the and maintain the intravascular volume. Hence, it will maintain the tissue perfusion and the oxygenation. So, on the other hand, we use fluid to maintain the electrolyte homeostasis. So, when there is electrolyte imbalance, we use fluid to correct it, those electrolyte imbalances. So, and also we use fluids, colloids or crystalloids or whatever thing, sometimes to as a medium to administer drugs. As I already told you, the fluid is a critical component of the perioperative period. Now we consider it as a drug. So it improves as a drug. The fluid will improve the perioperative outcome as well. So inappropriate fluid management definitely cause complications and the increased post-surgical morbidity and the hospital stay and sometimes the mortality as well. So as it is considered as a drug, so that we have to more conscious about when we are prescribing the fluid. So the every other factors will, the like indication and contraindication, like we are considering prescribing when other medication. So when we are prescribing the fluid, we have to consider about the indication and the contraindication. Where should we prescribe the fluid, or we shouldn't prescribe the fluid. And the contraindication, heart failure patients, that we have to be more cautious when we are prescribing fluid like that. And the type of fluid. Sometimes we have to use crystalloid, sometimes maybe we have to use colloid or even the blood products to manage that fluid situation in the patient. So as it is considered as a drug, so it should have a dose. It means sometimes bolus dose and the amount of the bolus and the rate of the infusion that we have to decide and the prescribe. And also that we have to consider about the side effects, that fluid itself carried side effects if it is being used incorrectly. Hypovolemia or hypervolemia can cause side effects. So when we talk about the type of IV fluid, so there are broadly two families of IV fluids, crystalloids and the colloids, and blood products we have to discuss separately, something separately. So colloids are the solution of electrolytes and other, colloids are mainly the solution of electrolytes and other small low molecular weight substances dissolved, which is dissolved in water. When their ionic content is close to that of extracellular fluid, when it is ionic content is close to extracellular fluid composition, we call them balanced solution. Because the particles are small, they pass easily across the vessel wall. So colloids are a little bit different. They carry high molecular weight particles, and those large molecules are meant to stay inside the vessels and hold water with them. So that is why colloids are considered as sometimes fluid retainers and the fluid expanders as well. Yeah, so the crystalloid again divided into balanced and unbalanced, depending on how close the composition towards the composition of the plasma or the blood. So some are considered as balanced and unbalanced. We will discuss it later about that later in the next few slides. Colloids that can be divided into again the natural colloids like albumin and the synthetic colloids like gelatin, dextran, and the starches. Again, starch only can be divided into balanced and unbalanced starches, which we'll discuss in the next few slides. So IV fluids. The crystalloids again can be divided, as I already told you, balanced one. The examples are Ringer's lactate, Ringer's acetate, which we not commonly heard about, Ringer's lactate, Ringer's acetate, and the plasmalite. And unbalanced one is the 0.9 saline, which we called it as normal saline, but now you know that it is not normal. The only normal factor is it is the tonicity of the saline, but everything else is not normal when compared to the other balanced crystalloid which is available in use. Okay, so among the colloids, you can divide them into two again by chemistry. I mean, biochemical arrangement. Such as gelfusin, hemocell, and dextran, and versus starches, hydroxyethyl starches, and voluene are the commonest available colloids in the hospital and the world. Natural colloid which is available, the only thing is the albumin, and synthetic ones are the again the above mentioned dextran and gelatin. So this table, the next slide, that this table compares what is actually inside these fluid bags, and we'll discuss, start with this osmolarity. Normal plasma osmolarity is about 275 to 295 millimoles per kilogram, and the balanced solution, and that is the osmolarity of the balanced solution is more closer to that normal plasma osmotic range. So that is another reason which it called as balanced solution. The electrolyte composition and the osmolarity is also closer to the what of that of the plasma. Then we look at the chloride composition. So the balanced crystalloid or the colloid fluid or colloid will have chloride level which is closer to the plasma. But when considering saline, the chloride content is much more higher than the that is of plasma. So the next, the buffering ability. Balanced solution, I mean, whatever the colloid or the crystalloid, balanced solution contains a buffer, as example lactate or acetate, to help maintain acid-base balance in the body or inside the solution. And but the saline, which is commonly available and which we are commonly use, it has none of the buffers in it. The balanced solutions, I mean the buffer solutions, the pH is near the physiological pH, while the saline is considered as an acidic solution. You can see the pH of the saline and the osmolarity of the saline in this table. You can see the electrolyte composition as well. So by using balanced buffer solution, so there won't be any significant acid-base derangement even if you have given large volume of those solution into the body. But when considering saline, if you have given large volume, it can lead to hyperchloremic metabolic acidosis as the saline itself is an acidic solution and it has contain supraphysiological chloride contents. And I need to tell one common mistake that we are thinking about, that whether if we have given Ringer's lactate, I mean the balanced solution, one of the balanced solution, Ringer's lactate, does it increase the lactic acids in the body? No, it doesn't. So the lactate which contains in the Ringer's lactate ultimately will be metabolized into the bicarbonate inside the body, and the pH will be neutralized or behave very closer to the body pH. So it doesn't increase significant lactate inside the body even if you give large amount of Ringer's lactate into the body. So the picture, this picture, it shows the fluid distribution inside the body. So you can see the colloid retained in the plasma and the sodium chloride, the saline and the crystalloid usually go out of the vessel into the interstitial. So that will be distributed in the extracellular compartment. So the glucose solution, like 5% dextrose, as the glucose will be ultimately metabolized inside the body, you will be left with only water, so it can be distributed everywhere inside the body, including the intracellular fluid. So the fluid colloid is considered to be retained in the vessel, and everything else will be, I mean, the balance or unbalance or whatever the crystalloid solution will go out of the vessels freely. So the balanced crystalloid, so we have already discussed about these things later in slides, the previous slides. So the balanced crystalloids are the Ringer's lactate, Hartmann solution. We have already but there are very few side effects, or we have to be very cautious when using the large volumes of Ringer's lactate. It can it contains some amount of potassium, which can increase the potassium levels in the patient who is having already high potassium. It means already hyperkalemic patient. It can increase the potassium levels. So so we have to be more cautious. So it also contains calcium, Ringer's lactate, so that we have to be very cautious when we mixing it with some blood or some other susceptible medications. And although it is considered as balanced solution, so it is slightly hypotonic. So we can't, as hypotonic, and it contains a less amount of sodium, so which we can't, we usually don't use in traumatic brain injury patients. So normally the sodium chloride is commonest one which we can use in a traumatic brain injury patient. So coming to the normal saline, 0.9 sodium chloride. So it can be very safely used in patient who is having hypochloremic situation like vomiting and frequent gastric suction, and also can be used in hyponatremia with deep chloride depletion. So hypochloremic and low chloride situations. Again, hyponatremic and low chloride situation like recurrent vomiting and like situations. And that can be used in neurosurgery safely and traumatic brain injury patients because it contains high sodium concentration, where we have to maintain high concentration in the patients, brain injury patients and the neurosurgical patients. So the disadvantages are hyperchloremic metabolic acidosis. It can cause hyperchloremic metabolic acidosis, and there is a risk of developing AKIs. So the glucose solution, when we consider, so again I already told you, so they can be used to correct the hypoglycemia, and we can use it in a situation where we need to give like electrolyte free solution into a patient, like in endocrine conditions like uh, like the diabetic insipidus, where all the free water will lose from the body, and you will have hyponatremia in plasma. So you have to correct the hypovolemia as well as the sodium levels. So you can't use the solution which contains sodium, high sodium, like normal saline, even the Ringer's lactate. So in such situations, we can use glucose solution, which is free of sodium. Human albumin solution, which is the only new natural colloid that we are having at the moment. So the indication are that we can use it for the situation with hypoalbuminemia, and when we manage the major blood loss or the massive transfusion protocol is not indicated in massive transfusion protocol, but we all know that we start albumin saline till as a bridging therapy till blood arrives into the theater or the practical situation. So that is one most important indication to use albumin. And also it can be used in burns patients and liver disease, patients with liver disease as well. And disadvantage is the albumin is lot expensive, and it's not evidence-based to used in routine surgeries still, but under investigation. It's under investigation. So after sometimes that will be comes as a recommended fluid element of fluid management perioperative. So still, but we use it as a bridging therapy till our desired colloids or the blood products available. And there had been few trials done, safe trial that gives some supportive evidence that we can use albumin as the first line resuscitation fluid, but it's not further evaluated. So post-operative quality initiate, that is one of the largest quality improvement project, and the audit that has been done so far about the perioperative management. So the albumin has been showed some positive evidence when it is being used in major surgeries, but it also needs further investigations to recommend. So the synthetic colloid, I don't think that we have to discuss about these things in detail. So the colloid major indication to use is, so if we need to increase, I mean in hypovolemia or the severe bleeding condition, if we need to replace the intravascular volume, so we have to use the colloid rather than giving a lot of crystalloids. So which will retain, the colloids will be retained more in the vasculature till till the blood is available in the theater. So as a bridging therapy again. Yeah, so the disadvantages are, so the cost is also again high. So the allergic reactions that can happen for gelatin and dextrans, sometimes it interfere with the blood cross matching as well, and it causes a coagulopathy, as example dextran, and it can cause the renal injuries as well. So the current recommendation, avoid synthetic colloids in critically ill or septic patients. So we all know now we don't usually use the colloids when we resuscitate a septic patient. The only example I can remember, so the dextran is used in management of dengue these days, so it is being commonly used in leaking patient. So the fluid strategies, this is the main part of the discussion. So there are three kind of fluid strategies that we have to know, but only the last one, goal directed fluid therapy, will be the best updated and recommended fluid therapy that we have to use in the perioperative period. The other two, liberal and restrictive or the zero balance fluid strategies, are now out of date. So, but we have to know about the difference in between three of the fluid strategies. So this picture will show you the main difference in all three fluid management strategies. On the left side, the liberal, that will show the liberal, about the liberal fluid strategy. So it recommends to give more fluid because it secures blood volume and organ perfusion. That is the main aim actually. So give more fluid to replenish the blood volume again inside the vessels, and that will lead to proper organ perfusion. But the complications are, I mean, the tissue edema will be there and delayed recovery, and so those can be the complication. But on top of having those complications still, so in past they have done practice this liberal fluid strategy to manage the patients. So the ultimately patient will be at risk of fluid overload, edema, and because of the tissue edema and all, there will be delayed recovery and airway complications and wound problems with the wound healing, anastomotic leak, and everything. And the next is the restrictive strategy. So where we give a restricted amount of fluid, and that will be, I mean, less fluid. As a crossword, we will use less fluid. So the patient, I mean, there will be, I mean, by using less amount of fluid, there will be a reduced risk of fluid overload. And but the still patient will there can be a risk of patient becoming hypovolemic and the hemodynamically unstable. And so because of the low volume and the tissue perfusion, we also can get deranged, or so the ultimately end organ also can get affected. So not like those two liberal and the restrictive strategies, the newly introduced one is goal-directed strategy. Actually, that is the main uh, topic we have to discuss today. So that will I mean recommended to give the right fluid at the right amount to the right patient. So the amount of fluid that we have to give will be guided by the monitoring, I mean the invasive or non-invasive monitoring, dynamic parameter depending on the static and the dynamic parameters of the patient. So that will be fully personalized, individualized management. Uh, uh, um, yes. So Um, and main aim to follow the goal-directed strategy is to optimize the tissue perfusion and maintain the vascular volume and optimize the tissue perfusion, and that hence that it will ultimately increase the patient's outcome, improve the patient outcome as well. Yes. So the goal, you can see the bottom, the mentioned the sentence. So the goal is to maintain the perfusion and organ function while avoiding fluid overload. So we are supposed to give just right amount of fluid at the right moment. So uh, shall we discuss about each and every fluid strategy in brief separately? So we'll start with the liberal strategy in detail. So the main idea is the generous, I mean, main idea is to give generous amount of fluid before, during, and after surgery. So you give you usually in this fluid strategy we give more than the volume, more than the calculated or measured losses. So the goal is to maintain high intravascular volume and avoid hypovolemia at all times. In practice, that means large volumes of colloid. I mean, we have to, so to achieve that, we have to give large volumes of crystalloid with or without colloid, and little restriction on how much is given. I mean, we can give both crystalloids and the colloid. Uh, uh, just aiming to maintain the intravascular volume. So you don't have to, I mean, know about in detail about these old fluid management strategy. Just have I mean, rough outline about the things happen. Uh, so so that usually it is being used for major surgery and uh, just to prevent hypovolemia, because major surgeries there can be a very big fluid shift, bleeding and all. So the fluid is being given just to maintain and avoid the hypovolemia and restore the fluid, intravascular volume. Um, so basically uh, the potential benefits of this management strategy are the maintain circulating volume, and that will hence maintain the organ perfusion finally, and then it reduces the hypovolemia and hypotension. And there are ගොඩාක් fluid volumes තියෙනවානේ එතකොට, so the hypovolemia won't be there and the hypotension also won't be there. So and that is easier to follow as well. So everyone giving fluid, giving, and looking at the urine output and nothing else. And till the patient develops some urine, so the patient is being filled with the fluid. And there are potential risks on top of the patient can be fluid overload, of course, and tissue edema. There will be tissue edema, peripheral edema, and impaired wound healing, pulmonary compilation like pulmonary edema and all. And there will be delayed recovery, and finally there will be long hospital stays because of this wrong fluid management. Uh, So that is not being practiced now. So you don't have to keep it those things in mind. Otherwise, you will start practicing them. And there was a strategy called this one, and so someone has told you. So you can be mixed up the management strategies and do these things. So just try to forget these things, and we'll consider about the goal-directed management later. So in liberal fluid strategies, mainly, as you can remember, so we replace the deficit and the maintenance and the ongoing losses. So we calculated according to the body weight and give large volumes of fluid without considering the patient's other parameters or the patient's fluid responsiveness prior to the fluid administration. So mainly in the liberal fluid strategy, I have to tell about this third space loss. So the third space, so you can see in when they are doing laparotomy, so you can see the lot of fluids being evaporated, and so fluid will come out from the peritoneum, bowel will be opened, and everything will come out, and those will be lost from the body. So there was a method to calculate that volume and replace it without considering the patient's fluid status. That is happened in the liberal fluid strategy. So if the patient is having moderate tissue trauma, so there will be a calculation method to give this much of volume fluid need to be replaced here. So in severe trauma, so the fluid quota will be much more than that. So like that, third space loss, evaporative loss, and also the together with the blood loss, all will be replaced irrespective of assessing the patient's fluid responsiveness and the current status of the patient's fluid status. So not like in a liberal thing, then people used to practice restrictive fluid strategy, because patient who had liberal strategies had a lot of complications, and then they started to cut down the fluid in perioperative period, which is called restrictive fluid strategy. So the main idea is to administer the minimum amount of IV fluid required to maintain adequate organ perfusion and avoid fluid overload. Organ perfusion තියාගන්න විතරක් adequate fluid ටිකක් දෙනවා. But that is also not depend on the patient's fluid status or the fluid responsiveness. So irrespective of whether the patient is being hypovolemic or not, still they continue to give less fluid during the operations. The main idea is to avoid the overload and promote the recovery and avoid the complication which we had by using the liberal fluid therapy. So the practice was to give less fluid than the calculated or measured losses, replace only ongoing losses and deficits. එතකොට deficit initial deficit replace කරන්නේ නැහැ. So they will replace only the ongoing losses, and the ongoing losses and the deficit only will be replaced. So goal is to maintain the euvolemia, but patient can be wrongly become hypovolemic as well, which we don't know because we don't look at the patient's parameter and the individual things, and only restricting the fluid. So typical practice was to give small amount of crystalloids, avoid fluid boluses, and like liberal loadings. So sometimes as they have used inadequate fluid, sometimes the blood pressure also can go down and patient become tachycardic, and so they tend to use early vasopressors and all to keep the blood pressure up without giving any more fluids. So the potential benefits of this method was like reduced risk of fluid overload, obviously, and less tissue edema, and improved lung functions and the oxygenation. Uh, and sometimes it was more important when the patient underwent bowel surgeries and anastomosis like that. So the wound healing and the anastomotic healing, it was like more effective. And so the patient had shorter hospital stay, and overall patient had better outcome when compared to the liberal fluid therapy. But at the same time, patient had potential risk of developing hypovolemia, hypotension, and organ hypoperfusion, which can leads to acute kidney injuries and the other organ malfunctions, including lactic acidosis, because of the poor peripheral perfusion. Mm, yeah. So the main purposes, like I have already told you, so to maintain the zero fluid balance in the restrictive strategy, and they just only give the maintenance fluid, and they didn't use boluses, and deficit sometimes ignored unless patient is dehydrated or severely hypotensive because the hypovolemia. Uh, Third space just rejected. It's not being replaced. Evaporative losses, they very minimally replace that one. Blood loss replace its crystalloids or colloids in 1-to-1 ratio. The crystalloid, if you need to replace the blood loss, they could have used the crystalloid 1:3 ratio, but they haven't done that in that restrictive fluid therapy. Blood loss also replaces the crystalloid 1-to-1 ratio. And they have used this early use of vasopressors to maintain map to keep the blood pressure and the organ perfusion. So the evidence, so the observation and studies has been done. Some and it shows liberal versus restrictive strategy they have compared. So the liberal strategy, the observation and study showed that there are increased complications such as pulmonary and wound healing, anastomotic leak, and everything, and it increased the hospital stay as well. Restrictive strategy, it also has reported as carried a bad effect, and patients develop AKI. So both methods had bad outcomes at the end, according to those observational studies. But there was a large randomized control trial, which is called relief trial. So that has compared the liberal and the restrictive fluid strategies in major gastrointestinal surgeries. So the restrictive strategy carries high rates of surgical site infection again and AKI because of the hypovolemia, and similar disability. I mean, like in fluid liberal and the restrictive strategies, the ultimate 1 year survival and the disability was the same. So no, either methods had no good outcomes after doing some evidence-based, after doing some researches and the trials. So in this picture, you can see both hypovolemia, too little fluid, and hypervolemia, too much fluid, is not good for a patient because it carries set of bad effect and the complication of the patients. So and this slide I added additionally because just to explain how the hypervolemia can cause complications in the patients. Hypovolemia itself uh, increases the pressure in the interstitium. It compresses the capillaries and lymphatics. So as you can see in the first box, it worsens the organ fusion and the oxygen delivery. So uh, the patient will have high lactate levels and the patient will become acidotic because of the poor peripheral perfusion. And the second one is when the patient is becoming hypovolemia. Again, I already told you that atrias will be distended and start releasing ANP, which has direct shedding effect on the endothelial glycocalyx. So the vessel permeability will be high and more fluid will be leaked into the interstitium and tissue edema will happen. Okay. So the third box, why the high fluid volumes can cause AKI. So it increases the pressure inside the renal parenchyma, which reduces the blood flow into the calyxes and everything. And so the renal filtration pressures will be affected, and the ultrafiltration also get affected. So there will be reduced urine output and the toxic clearance, so leading to AKI. So that is how the high fluid levels causing bad consequences in the patient. So when we talk about the goal-directed fluid strategy, this is the topic of the day, and the so the goal-directed therapy main idea is that is individualized fluid therapy using dynamic assessment and the monitoring of active, dynamic assessment and to monitoring to achieve optimal performance. So if the patient so we don't have to keep the patient hypovolemic or the hypovolemic. We have to give the titrate amount of fluid. So we have to have a guide or the goal to lead our fluid management. So we can use the dynamic and static uh, parameters to assess the patient's fluid responsiveness. So rather than giving fluid blindly, we can see whether the patient is fluid responsive. We can initially assess the patient's fluid status and whether the patient is dry or the hypovolemic to begin with, or the hypovolemic to begin with. If the hypovolemic, we have to replace the deficit or the things before the surgery in the preoperative period, before the patient come into the surgery. Like in patient, if the patient is having diarrhea or vomiting, so the patient will be dehydrated when the patient comes to theater. So you have to correct the dehydration part to start with the surgery usually, which we do usually. So and also you have to see whether the patient is fluid responsive. If the patient is fluid responsive only, somebody can have more fluid boluses or whatever the infusion. If the patient is not fluid responsive, there is no space to give fluid. That will cause more detrimental effect being by giving fluid into the non-fluid responsive patient. So to practice this one, so we have to use the dynamic parameters and monitoring the patient's parameters to guide fluid administration, to give fluid only if the patient is likely to fluid, if the patient is fluid responsive. Okay. I got the message, madam. Okay. So if the both extremities of the fluid management, as we discussed previously, cause harm effect, so answer is to individualized goal-directed fluid therapy to practice. So the main idea is to guide fluid with dynamic assessment and real-time monitoring, giving fluid only when the patient is likely to respond to fluid. So the main goal here in the goal-directed fluid management is to optimize cardiac output of the patient and the tissue perfusion while avoiding both hypovolemia and the overload. So initially, so we'll move into the next slide. That is the same thing has been mentioned in the next slide. So, okay. So the main aim is to of the goal-directed fluid therapy is to optimize stroke volume and the cardiac output and the tissue perfusion, and avoiding fluid overload. The patient's fluid responsiveness is used to guide fluid, vasopressors, and the inotrope therapy. If the patient is fluid responsive only, we give fluid. And sometimes, even without giving fluid, we can use vasopressors and the inotrope therapy to maintain the cardiac output and the stroke volume to maintain the tissue perfusion. That is the main goal. The fluid responsiveness depends on where the patient is on the Frank-Starling curve, which we'll look at later in slides. And fluid responsive always doesn't mean the patient is hypovolemic. The patient can be euvolemic or the normovolemic or the hypovolemic. Because of the, I mean, even though the patient is fluid responsive, it doesn't mean that you have to always give fluid. And because patient can be high normovolemic as well, where the patient doesn't need further fluid boluses. So the assessment of the fluid responsiveness, it means, I mean, fluid responsiveness means the ability of the cardiac output or the stroke volume to increase in response to fluid bolus. අපි fluid bolus එකක් දුන්නාම cardiac output එක හරි stroke volume එක හරි වැඩි වෙනවා නම් it means the patient is fluid responsive. So if the patient is not fluid responsive, additional fluids shouldn't be given. So in this Frank-Starling curve, so you can see the x-axis as the preload, y-axis as the stroke volume. So there are two stages, A and B. In the part A, the Frank-Starling curve shows with the little increase of the preload, stroke volume increment will be more higher. It means patient is more fluid responsive. In the part B, in the plateau phase of the curve, with the preload, even with the significant preload increment, the stroke volume increment is very low. It means patient is poorly fluid responsive.
Excuse me, Dr. Buddhika, we have another 20 minutes to go.
20.
Yes.
Is it
okay,
20?
thank you.
So here, so this slide showing the brief, I mean, how we need to measure the fluid responsiveness and how we measure the fluid responsiveness. What are the modalities available to see whether the patient is fluid responsive or not? So to implement this goal-directed fluid therapy, so we have to first assess the patient's baseline fluid status. We can use the heart rate, blood pressure, and the other clinical examination findings, intergo, mucous membrane, hydration, and all. And then we move with the after assessing the initial fluid status of the patient, we move to see whether the patient is fluid responsive or not. So in that stage, we can use static or dynamic parameters. So the dynamic parameters are the best parameters or the monitoring modalities to assess the fluid responsiveness. I will discuss it later. So if the patient is fluid responsive, then you can give a fluid bolus like fluid challenge to see whether, I mean, you have to first implement a method to assess the fluid responsiveness, like if the patient has got heart line, so we can see pulse pressure variation, stroke volume variation. So the new modern monitors will automatically show the things in the monitor. So the pulse pressure variation, if you have established some monitoring modality, then you can give a fluid bolus to see whether the patient is fluid responsive. It means after giving the fluid bolus, patient will, after some time, increase the stroke volume or the cardiac output. If we have a method to monitor cardiac output, like cardiac output monitoring like thing, so we can see the significant increment of cardiac output after giving the fluid bolus if the patient is fluid responsive. or else we can use the map as a surrogate to see the changes of the cardiac output, hence the blood pressure. So if the patient is fluid responsive, then you can give more fluid. If the patient is hypovolemic, or if the patient is hypovolemic, or if the tissue perfusion is deranged. So those are the two decisions that we can take. So as this algorithm shows you, after giving the fluid challenge, you have to reassess the response and whether the patient's increase in the cardiac output or not. So that will say that patient is fluid responsive. So then we can decide the next step, whether to give fluid or not to give fluid. If the patient is having reduced peripheral perfusion, which we can measure from lactate levels and so mixed venous oxygen saturation and all. So we can give some fluid to increase and see whether patient is recovering from those complications as well. So this slide will show you how the static and dynamic parameters works. So you can see static parameters are the poor predictors of fluid responsiveness to measure the assessing fluid responsiveness, like heart rate, and it is very non-specific. Blood pressure, usually we see the map, and it can be influenced by many other factors as well. And central venous pressure, which is not being used currently, and it's very poor correlation with the fluid responsiveness. And we can take the base as baseline and the trend of the CVP to assess the fluid, venous filling, central filling pressures, not the fluid responsiveness. Because of it comes as a poor predictor. So pulmonary artery occlusion pressure, so which that is a very invasive procedure which is not practically used in our settings, and you can use the urine output, and that can be a very delayed response. It's a real time so we can't see. So serum lactate, we can assess the serum lactate to show to see that peripheral tissue perfusion, level of tissue perfusion, and that is not ideally to use for the fluid to assess the fluid responsiveness. Capillary filling time, that is also a bedtime test that can be used. So it also can be varied with other factors as well. So the dynamic parameters are the very good predictors of assessing fluid responsiveness. In this green color table, you can see. So the dynamic parameters assess the changes in stroke volume or the flow with the phase of the respiration. Respiratory mechanism phase, respiratory phase එකත් එක්ක, so this cardiac the stroke volume එකේ variation එකයි, so the pulse pressure එකේ variation එකයි usually අපි බලන්නේ. So the most important parameters are, the dynamic parameters are stroke volume variation and the pulse pressure variation, which we can easily measure if the patient is having arterial line. Stroke volume response to fluid, if we can go through all the parameters here. So passive regress testing is also a practical test. It's a simple test that we can use to see the fluid responsiveness, very non-invasive, because we use the fluid volume. We use the blood pooled in the legs, and when we lift the legs up, the concept say auto transfusion of the fluid blood volume into the central compartment, because of that the patient will have the increased cardiac output or the stroke volume, which we can measure from the blood pressure or the artery line parameters. But it can't be practically used intraoperative period, and that is also will be ineffective in small kids. So the other parameters are the dynamic parameters are in expiratory occlusion test. So don't have. Just get an idea, so we don't use them practically in our settings. And IVC diameter variation, that is being practiced commonly. So you have to know about the IVC diameter. You have to assess the IVC diameter. You can assess the IVC diameter to assess the fluid responsiveness. I will discuss it later again. And aortic velocity time index, and other one is esophageal droplet measure parameters. Esophageal droplet is also commonly used in ICU setting, not usually we do in the intraoperative conditions, but we can use it in the ICU settings commonly, and that is also very good dynamic parameters to assess the fluid responsiveness. So the commonly used dynamic parameters are stroke volume variation, pulse pressure variation, passive leg rest test, IVC diameter measurement, and if you are competent enough to do echo, so then you can measure the aortic volume aortic velocity time index variation as well easily. Even if the patient's abdomen is open, you can keep the echo probe on the chest and assess the those parameters. The physiological basis of the dynamic parameters, so the extent of cyclical changes in hemodynamic parameters depend on the patient's position on the Frank-Starling curve, which we have already discussed. Commonly used hemodynamic parameters, as I already told you, the patient is having heart line, pulse pressure variation, stroke volume variation. I will limits later. And so if you are competent enough to do echocardiogram, you can assess the left ventricular outflow tract maximum velocity or the velocity time interval. That is a little bit of advanced parameter. If you are competent enough, you can assess that as well, because it is non-invasive. And other thing is, if you are good in ultrasound practice, so you can measure the inferior vena cava distensibility index as well. So I will come to that. So when we come to IVC assessment, so because it can be easily done and it is non-invasive. So in spontaneously breathing patient, usually we see the IVC collapsibility because the patient is breathing negative pressure ventilation, taking negative pressure ventilation. So the IVCs will be usually collapsed during inspiration. So in the positive pressure ventilation, if the patient is intubated and ventilated, so you have to see the IVC distensibility index. So that is because in the inspiration, patient will be actively pushed, the lungs will be actively inflated. So the IVC will be occluded, the intrathoracic pressure will be go up, so the IVC will be temporarily blocked. So the IVC will be distended during the inspiration. So during the expiration, IVC will be again become smaller. So depending on the respiratory phase of the respiration, you can see those changes in the IVC. So you can easily measure by using this equation I have mentioned, IVC distensibility index. So that difference of the IVC diameter is divided by the least IVC diameter during the expiration and multiplied it by 100 to take the percentage. If that percentage is more than 18, so it means a patient is fluid responsive. But you don't have to straight away go and give the blood. So you can see whether the patient's blood pressure is okay, whether the patient is not tachycardic, if the patient is producing good amount of urine, and everything is good. You don't have to jump and give some fluid boluses in that situation. But at the same time, you can measure the peripheral circulation, I mean the perfusion, by doing lactates, mixed venous oxygen saturation if the patient is having central line, and the veno-arterial carbon dioxide difference if the patient is having arterial line. So if those parameters has been deranged, it means the patient's peripheral perfusion is not good. That may be due to the inadequate fluid in the system. So in that case, you can give a fluid bolus and see whether those perfusion indexes are now improving. So that is how this algorithm works. This slide shows how this goal-directed fluid therapy algorithm, together with the ERAS recommended, how we can implement in a patient. So as you can see, so we have to do the patient's initial optimization. We have to assess the patient's initial fluid status. If the patient is dehydrated and hypovolemic, you have to replace and optimize the patient before taking to the theater. And from that point, we are going to assess the patient's fluid responsiveness depending on the stage of the surgery. මුලින්ම පටන් ගත්ත ගමන් fluid responsiveness බලන්න ඕනේ නැහැ. When the patient is surgery is going on and the patient start bleeding and thing, if you are thinking that the fluid that you are giving is not adequate, or you are giving a lot of fluid on, then you can start. If the patient is having arterial line, you can start seeing the SV, pulse pressure variation, stroke volume variation, and all. And then you can have an idea if those parameters are low. So this slide shows if the patient is fluid responsive, your systolic volume variation, stroke volume variation, and the pulse pressure variation will be more than 30. So I haven't mentioned how to calculate this stroke volume variation and the pulse pressure variation. So that will be automatically come in your monitor. So there is a way of calculation as well, but now modern monitors, it will give for you for the calculation. So if those two parameters are more than 13, it means patient is fluid responsive. Then you can give a fluid challenge and see whether the patient is tolerate. If it is more than 30, patient is already fluid responsive anyway. So you can give some fluid. It means patient can accommodate some more fluid. So you can give fluid, and you can see if you are having any other cardiac output monitoring facility. So you can see after giving the fluid bolus, patient is really increasing the cardiac output and the stroke volume. So the patient is fluid responsive. If the stroke volume variation and the pulse pressure variation, as I mentioned in the middle part of this flow chart, if those two in between 99 to 13, it means patient can be fluid responsive or not. That is doubtful. So you can again assess the fluid responsiveness if you have these other assessing parameters, including static and the dynamic. So you can further evaluate whether the patient is really fluid responsive to go ahead with the further fluid. So if the patient is non-responsive for fluid, the stroke volume and the pulse pressure volume will be less than 9. So you can see them in the monitor. If they are less than 9, it means patient is not fluid responsive. So you can't give fluid. So you will cause more harm if you give fluid. So in that way, so dynamic parameters always guide you through to assess the patient is fluid responsive or not. The decision is on your hand to give or not to give the fluid, depending on the patient's other factors, as I told you earlier. What are those other factors? So before going to the other factors, the perfusion factors, in that next slide, you can see if the patient is so those stroke volume variation and everything, if the patient is having outline only, then if the patient is not having outline, how can we do the fluid response? Assess the fluid responsiveness. Yes, you can still assess the fluid responsiveness by using the simple other methods. So that is being showed in this slide, dynamic assessment without invasive lines. Yeah, so as this picture shows you, so you can see the pulse oximeter, any patient is having pulse oximeter, so you can have the pleth variability index, PVI. The modern monitors that will show that one. Okay, pleth variability index. If that pleth variability index is more than 13, like just same like your SVV and the PVV. So if it is more than 13, it means patient is fluid responsive. You can give some fluid. And other thing is, as I told you earlier, so if the patient's abdomen, or though the patient's abdomen open, you can still keep the echo probe on the chest and see the heart. So you can assess the left ventricular outflow tract velocity. If you are good in echo practice, and then if the VTI values, that is a little advanced one for you, so I don't go to in detail. So if the VTI values are more than 12 or 15, so that is also show that patient is fluid responsive. And very non-easy invasive method to check the patient's fluid responsiveness is bioimpedance techniques to see the patient's cardiac, assess the patient's stroke volume and the cardiac output. Electrical bioimpedance, and so this is bioimpedance techniques and all. So there are two methods, this NICOM and the ICON. Those two bioimpedance technique which used to measure the stroke volume and the cardiac. Still, those are advanced equipment that we don't use in the common day-to-day practice. And the esophageal Doppler is also a non-invasive one, and inferior vena cava is the next best commonly used thing. So among those parameters, the techniques, you can commonly use this pleth variability index to assess the fluid responsiveness, this echo transthoracic echo technique, and the inferior vena cava technique if the patient's abdomen is not being open. So moving to the next slide. So it recommends that the fluid responsiveness and giving fluid after that is not the recommendation is not use that hemodynamic monitoring technique alone, but it advised to use it together with the indicators of tissue perfusion like lactate levels, veno-arterial carbon dioxide difference, and the mixed venous oxygen saturation. Then lactate levels, now we can see even without outline, we can assess the lactate level. So veno-arterial carbon dioxide difference, you can take arterial carbon dioxide, you can take ABG and a VBG. Then you can compare the gap between the PaO2 of those two, VBG, and the PaCO2 of those two, VBG and the ABG. So that is usually about 5 mercury millimeters. So difference. So if that gap is become increasing, so it means there is something problem with the tissue perfusion. I will come to that. And even if the patient is fluid responsive, fluid is not indicated if tissue perfusion is normal. As I already told you, patient fluid responsive වුණ පළියට fluid දෙන්න ඕනේ නැහැ. හැබැයි ඔයාලා බලන්න ඕන peripheral perfusion කොහොමද කියලා මේ indices එක. If the peripheral perfusion also got affected, then you can decide on giving some fluid bolus as the patient is responsive, no harm giving fluid, and then assess whether the perfusion also get corrected. Moving to next slide. Again, lactate is also sometimes non-specific වෙනවා. එතකොට alternate causes තියෙන්න පුළුවන් lactate, high lactate වලට, liver failure, liver diseases and all. And if the patient is having liver disease and high lactate because of that, so the lactate trend of the lactate changes also will be get delayed. So you can't use lactase as such to monitor the peripheral oxygenation or the perfusion. Veno-arterial CO2 difference is at the normal value is 5. 40යි 45යි. ඔය දෙක අතර වෙනස 5යි. එතකොට if it is going up, so there is a stagnation at the tissue level, which the venous blood extract carbon dioxide more from the tissues to the blood, and then your venous carbon dioxide levels will go up, not the arterial leg. If your oxygenation and the lung function and the heart is okay, so the arterial carbon dioxide will not change as such, but the venous carbon dioxide will change because of the fluid, sometimes congestion, tissue congestion in the peripheries will stagnate the venous blood in the peripheries, and that will extract more and more carbon dioxide in the blood.
Rasika, extremely sorry.
Yeah.
You are run out of time, and we'll allow you to have an extra 5 minutes to wrap up your presentation.
Yeah. Okay. So veno-arterial carbon dioxide difference, that is we already discussed. If the veno-arterial carbon dioxide is high, don't jump and give some fluid straight away to increase the perfusion, and also you can see the mixed venous oxygen saturation as well. If the mixed venous oxygen saturation is low, it means sometimes cardiac output can be low because of the hypovolemia or the cardiogenic reason or the obstructive reason. Like that, if the mixed venous saturation is high, it means sometimes patient will have hyperdynamic situation where the heart without tissues, without being oxygenating, the blood comes to the right side of the heart with the high oxygen saturation. And sometimes in a septic condition, patient can having a cytotoxic hypoxia, where the tissues can't utilize the oxygen. So the ultimate mixed venous saturation also will be high. So depending on the veno-arterial carbon dioxide difference and the mixed venous oxygen, so you have to work it out whether the cause of these changes. What is the cause of these changes? So sometimes, if the veno-arterial carbon dioxide is high, your mixed venous saturation is low. That may be due to the hypovolemia. Then you can give a fluid bolus and see whether those parameters also will come up if the patient is fluid responsive. If the veno-arterial carbon dioxide difference is high, when the mixed venous saturation is low, then that is the problem may be due to some other reason where you don't have to give fluid. So the evidence-based, the goal-directed fluid therapy, the evidences are, so the Optimize 1 trial, it doesn't show the statistically significant reduction in complication and rate, and a 30-day mortality rate. But the subsequent meta-analysis has been done, few of them, and it shows that goal-directed fluid therapy it causes fewer post-operative infection rates and the reduced length of stay, which are the good outcomes. So the when go together, to goal-directed fluid therapy go together with the enhanced recovery protocol. So in pre-operative period, it says that to reduce the amount of fasting time as the fluid management. So the patient will be more hydrated, and they can be like closer to your volemic situation when the patient comes to theater. So the intraoperatively, it also advised to use the goal-directed fluid management. We discussed it now. And the post-operative period, the ERAS has advised to start early oral nutrition. So the patient bowel function will be okay. The hydration will be again restarted again soon, and the IV fluid, the risk of the duration of giving IV fluid also will be low. So the electrolyte imbalances and the fluid-related complication will be also low. So this is the take-home message of the today discussion. So consider fluid as a drug, and always try to use balanced crystalloid where you need to use crystalloid, and try to protect the glycocalyx layer while you are managing the patient's fluid, and not to become hypo or hypervolemic, hyperglycemic, and try to use some amount of albumin even if it is not study further, still not established. Avoid both, avoid patient being hypo or hypervolemic, avoid both extremes, and try not to prescribe fluid or give fluid depending on the static parameters or the numbers or single individual parameter. Try to analyze the dynamic parameters, which are the most accurate one, and titrate your fluid balance. Or when the patient is fluid responsive, it doesn't mean that you have to always give fluid. That keep it in mind. So that those are the take-home messages, and these are my references. And thank you very much. So keep in mind to give right fluid to the right patient at right time. Thank you.